What's going on, everyone? It's Alex here from Aleks Physio. So today we're going to be going over cervical radiculopathy. Before we talk about cervical radiculopathy, let's talk about what it is not. So it is not cervical myelopathy. So myelopathy is when the spinal cord has been injured or irritated and is causing symptoms that are different than cervical radiculopathy symptoms. What symptoms is cervical myelopathy causing? It is causing issues with balance, sometimes incontinence. It may cause pain, numbness, and tingling going down both arms versus just one. In addition to that, there are signs of clumsiness. So you finding that you're dropping things out of your hands or difficulty with manipulating fine objects. And this is more of an emergency versus a radiculopathy because obviously the spinal cord is affected and prolonged irritation or impact on the spinal cord can lead to longer lasting damage and changes if not dealt with promptly when you notice those symptoms. What is cervical radiculopathy not also? It's not TOS, so thoracic outlet syndrome. The difference lies in where the nerves are being irritated, whereas in TOS, they're irritated at 3 different places that are further along the spine than with radiculopathy. They're irritated around the interscalene triangle at the side of the neck, around the clavicle, and just below the pectoralis muscle region. And although some of the signs and symptoms are similar, the treatment may be a little bit different just because of, again, where the irritation is and subsequently what can be done with regards to it. Let's talk a little bit about what cervical radiculopathy actually is. So I'm going to bring this model over to describe. So we have our spinal cord that basically runs down our spine, and from here we have these little nerve roots that branch off of that spinal cord, and these nerve roots are running in these little foramen, these transverse foramen or these canals. And what can happen is with cervical radiculopathy is these nerve roots can become irritated, either as a result of inflammation in and of itself within the nerve root or around, but also with the actual foramen canal narrowing as a result of arthritis, disc herniation, degenerative changes, or a direct injury that's affecting that nerve root. And as a result, when that nerve root is affected, it causes motor changes or changes in the strength that conduction of that nerve root can send to tell the muscle to turn on. And depending on what level is affected or what levels are affected, you will notice differences in weakness in different movements on the affected side versus the unaffected side. So that's where we do something called myotonal testing, where we're looking to see if there is any fatigable weakness from one side to the other. The other thing we're looking for is we're looking for sensory changes. So when you touch an area of your skin, that is being supplied by a specific nerve root at a level that tells your brain which part of your hand that you're feeling. And when, again, there are irritations in that nerve root, what can happen is you may not feel that touch as strongly as the unaffected side works. So then we do dermatome. These are called dermatomes. So we do dermatonal testing where we're comparing both sides and we're looking to see if that produces the same sensation or a weakened or less sensation from the affected side to the unaffected side to our touch. And the other thing we're looking at is we're looking for reflex changes. So using a reflex hammer to look at different levels. So we have our triceps, we would check the reflex at C7. We have our brachioradialis, which is that muscle kind of on the front of our forearm. That's C5, C6, or C5 usually. And then C6 is the bicep reflex. So again, we're looking for differences from one side to the other. And those are, if there is a difference, if the reflex is absent or decreased, then that helps to confirm or make the diagnosis more likely to be a possible radiculopathy combined with other tests that we'll go over later in the video. Radiculopathy is basically a clinical condition where there are motor, sensory, and or reflex changes associated with the irritation of that nerve root. The important, very important thing to be mindful of is with an MRI, which is used to diagnose or help diagnose these conditions, there are a lot of false positives, which means that there's a lot of people that have these findings indicative of a disc herniation or irritation of those nerve roots, but have no pain traveling down their arms, no sensory changes, no motor changes, and no reflex changes. So it's important to combine the results from the MRI with the actual objective findings and the subjective complaints to guide your overall diagnosis. Because MRI is the gold standard. I mean, it can detect up to 90% of these cervical radiculopathies, but it's important just to be mindful that MRI is just one picture, and the MRI can pick up on anything, and it's hard to know whether or not that was present before you started having the symptoms or after, so it's important to take that within the whole context of the condition. We went over what cervical radiculopathy is. We went over what it isn't, which it isn't a myelopathy or thoracic outlet syndrome. How do we test, or what other tests do we do to confirm that diagnosis? So one of the tests is a Sperling's test, where basically there are different ways to do this test, but if you have symptoms traveling down the right side, we get you to side bend towards that side, and we apply pressure downwards. And we're looking to see if that reproduces the pain or the symptoms that you're experiencing down your arm compared to when that pressure isn't applied. And we sustain that for 5 to 10 seconds. The premise behind this is we're trying to close down, in theory, that canal, and then applying that pressure to see if that irritation on that nerve root is what's responsible for the symptoms that you're having. The test we're looking at is traction and compression. So we'll get you to lie down, and we're applying a traction force. So we're trying to quote unquote unweight your neck and try to increase the space where that nerve root is traveling to see if that relieves the symptoms, and a lot of people it does. And then we're applying a compression force where we're doing the opposite, where we're trying to close down that canal by applying the pressure downwards, and we're looking to see if that reproduces the symptoms. The other one we do is we do a shoulder abduction test. So sometimes people will report when they put their hands on their head, the symptoms are gone or less, because that is taking some pressure off of the nerve root. And sometimes people will be walking in this position. Another test that we look at is upper limb neurodynamic tension testing. So depending on which nerve is irritated and at which level, we're looking to see if there's a difference from side to side between the nerve testing of the irritated nerve. So there's nerve testing for the median nerve, which is the nerve that's implicated in carpal tunnel. We're looking at the radial nerve, which is the nerve that's irritated if you're using crutches underneath the armpit. And then we're looking at the ulnar nerve, which is the funny bone, quote unquote, nerve that gets irritated when you're resting on your elbow for long periods of time. And each nerve has a different test with regards to how it's provoked. And we'll go over this. So usually we would do it on the patient, but I'll just demonstrate how it can be performed as an assessment, but also as a treatment tool. So for the radial nerve, thumb in hand, fingers wrapped around thumb, wrist bend, elbow straight, and then from here, you're bringing your arm out to the side, and you're looking to see if that reproduces any symptoms or if that movement feels different from the unaffected side. That's radial nerve, that's one. Median nerve is we're starting with our elbow bent and wrist neutral, and we're extending our elbow, we're extending our wrist, and we're extending our fingers. And we're seeing if we have less range of motion with that movement compared to the unaffected side. And then the third one is the ulnar nerve. So we make an O with our thumb and our index, and then we're bending our elbow, we're rotating our palm up towards the ceiling, and we're lifting our arm up. Again, we're looking to see if that reproduces the symptoms going down the inside of our forearm and in our 1.5 fingers, or pinky and half of our ring finger. Whereas the median nerve supplies the first, second, third, and half of the ring finger. So those are tests that we can do as an assessment, but we can also incorporate that as a treatment. So now that becomes a neurodynamic technique or a flossing technique that helps with our treatment, that helps with some of the nerve mobility, helps with some of the blood flow to the nerve, and can also help with some of the symptoms. Those are called flossing exercises. The other thing to be mindful of is with regards to cervical radiculopathy, the recovery timelines can range from 6 months up to 3 years. That was discussed in a study by Wong in 2014, that it can take up to 3 years to recover. So our bodies have a tremendous capacity to heal. There are some conditions where healing can happen just with time and just with some simple movements, but cervical radiculopathy is generally not one of them. It's one that continues to linger, and the recovery can be quite lengthy. So it is important that you see a physiotherapist or a healthcare provider to help guide you on that journey, because that journey can be quite long. And the research also says 83% of people achieve a full recovery. Now, of course, there's nuance. What is a full recovery? Is it 0 out of 10 pain? Is it just back to your regular functions? but generally people do get better from this condition. It just takes a little bit longer. He compared doing manual therapy, exercise, physio, mobilizations versus a placebo or versus the wait and see approach. And they did find that the physio, exercise, manual therapy, education does better than just waiting and seeing or doing a placebo of something that somebody think may help, but it actually doesn't. The other thing that's important is with surgery, or if the possibility of surgery comes up in the future, generally what orthopedic surgeons are looking for is they're looking for all the signs and symptoms that we chatted about before, but how bothersome is the arm pain and the arm symptoms relative to the neck pain? Because generally surgery has a better prognosis if the arm symptoms are more bothersome. So if it's like an 80-20 with arm relative to neck symptoms, 90-10, 70-30, and you do have some of that weakness associated as well that we chatted about, and there are reflex changes, and there is a disc herniation or a nerve root irritation on MRI, all of these things tend to lead to surgery being a possibility to help the arm symptoms. Not necessarily with the neck symptoms, because that is a bit more hit or miss, but with the arm symptoms, generally more favorable with regards to resolution of those symptoms. But generally, at least in Canada, surgeons want to trial physiotherapy, conservative care first, and look at the overall individual first before just jumping right to surgery. But that may differ in different countries. So that's important to be mindful of, but obviously speak with your GP or surgeon if you have one that you're following about what the best option is for you, because of course there are things to be mindful of when undergoing surgery. Treatment. What are some other exercises that you can work on to help with some of the mobility and the pain and the range of motion and the discomfort? One of them is a chin tuck. So think of your chin like a drawer. The drawer is open when your chin is protruding forward. You're trying to close the drawer, make a double chin, and come back to the start. So that's helping to activate some of the deep and superficial neck flexor muscles at the front of your neck. Exercise number 2, we're just doing some shoulder retraction. So squeezing our shoulder blades together, coming back to the start, squeezing, coming back to the start. That's exercise 2. Exercise 3 is if we have symptoms on the right side, we're trying to work on some range of motion and some symptom control going the opposite way. So side bend away, back to the start. Side bend away, back to the start. Okay, that's exercise 3. Exercise 4, starting with our thumbs pointing out in front of us, we're lifting our arms overhead and a shrug at the top. Come back to the start. So arm overhead, nice and tall, shrug, back to the start. So those are some sample exercises that we would go over in a treatment program and progress from there based on how the tolerance is. In addition to that, reassurance, education, discussion on prognosis and timelines is super important to have somebody there to coach you and guide you along the way, because there are going to be flare-ups that happen throughout, but it's important that you stay the course, listen to your therapist and your healthcare provider. Another thing to be mindful of are just different positions that are a bit more tolerable. So we mentioned the hand on your head helps to relieve the pressure and the irritation on the nerve roots. The other one is, as we mentioned before, is if the symptoms are provoked when we side bend towards that side, because in theory we're closing down that canal when we side bend towards that side, the movement that's going to feel a little bit better is if we side bend away from that side, right? And side bend away from that side and even rotate a little bit as well to get some more mobility will help to take some pressure off, or again, in theory and sometimes in practicality, helps to take some of the pressure off. The other thing is hands in our pockets. So when you're walking, you have the forces of gravity and the traction pulling your arms downwards, but by having your hands in your pockets, that generally helps to relieve some of the symptoms, because you have that end point, because your arms are supported via your pockets, so it tends to generally make things feel a little bit better. So walking with your hands in your pockets may help things from a symptom provocation perspective. There you have it. We went over what cervical radiculopathy is, what it is not. We went over some different exercises that you can work on. We went over surgery. We went over some tests that we can do to help confirm our diagnosis of cervical radiculopathy. We went over some relief positions that may help from a symptomatic perspective. And we went over timelines and prognosis and what to expect if you been diagnosed or think you've been diagnosed with cervical radiculopathy. Let me know what your thoughts are in the comments below. Have you had cervical radiculopathy before, or are you currently going through it now? What's worked and what hasn't worked? And until then, we'll see you in the next video. If you found that this information was informative and valuable, please consider subscribing and liking my channel. It really allows my channel to grow.